Dr. Achla, this is hand painted?
Yes, ma'am, hand painted. Hand painted. She spent a month doing it.
Oh.
मैडम पहले आप बताना चाहेंगे कि पहले हम?
हाँ डॉक्टर साहब, मैं बताना चाहूंगी, वो ज्यादा बेटर है.
हाँ. मिस्टर जोर.
यस मैडम.
आप थोड़ी देर के लिए लाइव स्ट्रीमिंग बंद कर देंगे?
ओके मैम, जस्ट अ मिनट.
डॉक्टर लाइव स्ट्रीमिंग में कोई खराबी नहीं है डॉक्टर. एनीबॉडी हु इज हियरिंग शुड नो. ये डॉक्टर साहब जब आप करोगे तो उसमें डिलीट हो जाएगा ये ऑटोमेटिकली. ये इनको बोलिएगा ये डिलीट कर देंगे बिफोर दे पोस्ट इट. ठीक है?
हाँ जी.
If you want, we can be without live streaming also.
Whatever you say, madam.
नहीं, मेरे ख्याल से लाइव में होने से क्या डॉक्टर साहब, जितने लोग हम लोग जवाब कहाँ तक देते रहेंगे डॉक्टर साहब?
ठीक है मैडम.
I think that people should know.
ठीक है मैडम. मैडम आप.
Should I start?
Yeah.
I'm Dr. Sharda Jain. I have something bad to share with you. There are moments in life you suddenly become very quiet. You have no words. 16/3 is a bad day. It had been a personal loss to me, and I think DGF has lost a great friend and a well-wisher. Dr. Surjit Kapoor, great friend of ours, is no more. Everybody's asking what happened to her. People saw her on 13th dancing. People saw her on 12th. People saw her, this activities which had been going on for a Women's Day celebration for almost a week. She has been seen by everybody as a happy soul. She's no more. And I just wish to put in record that she has committed suicide. No note, no talking to close friends. And this puts me that personal emotions must be respected. Stress, everybody has stress morning, evening. It has to be shared. There's no point having a vibrant body of 2,500 or more people if you can't share things, if your close friends do not know what's going to happen. So I'm glad on one side that, Dr. Achla Batra has planned a academic session for 2.5 hours, at least for 2.5 hours, your mind is not going anywhere. But this is my personal request that अपने friends की emotions को पहचानिए, उनको एहसास दिलाइए कि वो उनके साथ हैं. And I think, one should see to it that, things of this kind should not be repeated. And this can only become that we become less academic and we spend little more time with each other and talking and sharing with things. So with these words, I will again inform that Dr. Sajid Kapoor is no more. So with these remarks, I will ask Dr. Achala Batra to take over.
Indeed, it is a sad day, but as it is said, zindagi ka karma chalta rehta hai, nothing stops. So we will, though we all are feeling very bad, and may her soul rest in peace, but the life goes on and everything as planned has to go on. So we have this program on respectful abortion care today, which has been planned by WHO. Yes, ma'am. Madam, can't hear you.
1 मिनट के लिए अपना silence करेंगे, फिर आप ले लीजिए.
हाँ जी. So we will all observe silence for 1 month before we start our program.
Go ahead, doctor.
So as I was saying, the life goes on, so will our program, but may her soul rest in peace and let her family have the strength to bear the loss. So today's program was about respectful abortion care, was envisaged by WHO and FOXY. And why? Because we have had the abortion law for last 50 years, but if we see the statistics, even today, unsafe abortion constitute 1/3 of the maternal mortality. So reviewing this situation, it was thought that one must find out what is the cause, and one must revise, the methods of safe abortion. And not only that, in this program, we will be revising the, evidence-based data on methods of safe abortion and the continuum of care from pre-abortion to post-abortion and counseling. But more important than that is the reason why unsafe abortion occur is because the woman doesn't feel confident or to come to a healthcare provider, thinking that she will be looked down upon if she's married, or if she's a grand multi and she hasn't used contraceptive, she'll be scolded. So they go elsewhere. So there's a very important component of this safe, respectful abortion care is that when, as a care provider, we are providing abortion care, the experience of the woman should be such that she has confidence in the care provider, she listens to the care provider, and it is the duty of the care provider to get that confidence by treating her with respect, maintaining her dignity, maintaining her autonomy, and do not disrespect her. So this is the basic idea behind, and this program has 4 modules. The first module is about providing new information, whatever becomes available regarding abortion. So we have the MTP Amendment Act, which came in 2021. We all know it. So I would be discussing that. This would be followed by evidence-based review on the safe abortion methods. And then I would be taking up the section, which is the most important section I feel of this program, is how we health providers can change our bias, prejudiced, and not behave according to what the society say is the norm, but to look at the person who is seeking abortion as somebody who is your own. You have to show empathy to her, that we have to change. The third section, the WHO Saver module, is about that. And then we have the counseling module, in which how the pre-abortion and post-abortion counseling should be done, what all the component that would be discussed. So first of all, I would be sharing, the section on what we have what we know about the, just a minute, I'll just share my slides. Mr. Joel, I cannot share my slides. Mr. Joel?
Yes, madam.
It says the host has disabled sharing. So have you enabled me?
Yes, madam. I made you co-host, madam. Can you try once?
Yeah, I'll just check. Are my slides visible?
No, madam.
Not
Can't
is
see nothing.
okay.
No, doctor.
Go to share screen, madam.
I'll just go there. Just give me a moment. Now they are visible?
Yes.
Yeah. So this module 1 is about the medical termination of amendments which were done in 2021. It was really an historic move on part of India to have had these amendments. We were one of the first few countries who had a legal medical termination of pregnancy act in 1971. And then in 2021, we have this amendment. And I think we are one of the first few countries who have done that. And why we have done it? Because when in 70, the first law was made, it was made because there were a lot of unsafe abortions due to MTP being illegal and people were going secretly for MTPs. But then in 2020, there was a boom of how to do safe abortion, but still we were not able to decrease the maternal mortality due to unsafe abortion. That is why to expand the ambit of safe abortion, this law was amended. So let us have a look what are the new laws and what are the changes which have occurred. As I've already said that 8% of maternal death per year are due to abortions, and it is the third leading cause of maternal mortality. And 2 out of 3 abortions are unsafe. And half of the pregnancy-related deaths occur in the women and girls who are very young, less than 24 years. So that means we need to have safer method of abortion. And by WHO definition, it has to be an appropriate method by a trained person and in a designated place where all the facilities are available. So now these amendment, I will just touch on the salient features of Amendment Act. The previous act said that you required the opinion of one provider for MTP up to 12 weeks, and you required opinion of 2 providers from 12 to 20 weeks. The amendment is that up to 20 weeks of pregnancy, only requirement is of 1 RMP, and you require the opinion only after 20 weeks. So because there are many facilities where the second RMP may not be available, the one who is available may be very competent, but then for want of another person to be there, she or he cannot perform MTP. So this will increase, the facilities where MTP can be done up to 20 weeks. Previously, MTP was not permissible beyond 20 weeks, and it was only permitted if it was necessary to save the life of the pregnant woman. But now this limit has been enhanced to 24 weeks and special vulnerable category of women who require MTP between this. Why 24 weeks? Because 24 weeks is generally considered the lowermost limit of viability. And for birth defects, there has been no upper limit, because we've had cases, where woman having such a baby who is alive, but so malformed and has such deformities that giving birth to that child may not survive or may be having many anomalies, but MTP is not allowed because it was diagnosed after 24 weeks. And there are some defects, kidney or cardiac defects, which get diagnosed after later. And sometimes, when the woman is going from one place to other, being referred after 20 weeks, the time becomes over. So this vulnerable women who are between 20 to 24 weeks will be able to get MTP done by opinion of two providers, and those having such defects which are not compatible with life will be able to get MTP done even at any time of pregnancy. So this is a great help to such women. Then previous act, like I said, that if there was birth defect and anomalies, then also only up to 20 weeks we were allowed to terminate, and beyond 20 weeks they had to move a medical board. And now for between 20 to 24 weeks, without much ado, with just the opinion of two medical practitioners, they can get the medical abortion done, and beyond 24 weeks they will need a medical board. So this is also a great change in the act. Then previously, it was that if there is a failure of contraception, that was only applicable if the woman is married. Now, with the changing of scenarios, there are women who are not married and are using contraceptive, which can fail, or her partner is using contraceptive, which can fail. Then she should not be denied medical termination of pregnancy, so that she has a safe and legal abortion. Then the dignity, the respect, the confidentiality, that has become an important part of this amendment. Now, the information about the woman is not to be disclosed to anyone except under authority of law. And what is being done in public sector is, in a hospital, when a patient comes for MTP, when she is sent for getting her card made, we don't write her name on the admission slip. It is only the number which we give from a register, which is mentioned. So when she is in ward or wherever her MTP is being done, nobody knows her name, nobody knows where is she from, nobody knows she's married or unmarried. So her information is confidential if she doesn't want to leak it. But the records have to be maintained. So we have a register in the OPD where full record of the patient, the consent form, all are filled, but they are kept under lock and key. And by referring to the register, we can take out the record of the patient if required by law at any time. Many times the questions come, do we write the name in the discharge? Yes, you write the name in the discharge because discharge is being given to the patient. So her confidentiality is maintained. The other big thing in the law is that previously when a minor was coming for MTP, it was mandatory that a guardian or parents have to be with her. Only then she can have termination of pregnancy. But now the new law says that if she comes with somebody who is more than 18, that person can give consent. But do not confuse it with the not informing to police, because under the POCSO Act, anybody who's under 18, you have to report that she has become pregnant and has come to MTP, but that does not mean that there would be a case, but only the police information has to be given. So this will increase the privacy, the confidentiality of the abortion seeker, and also they will have more faith in you. They would listen to you. So the salient feature of the MTP amendment is that the name and the particulars are kept confidentiality to give a respect and maintain her dignity and confidentiality. And also, the ground of failure of contraception has been extended to women and her partner, irrespective of her marital status. So, we said that between 20 to 24 weeks, vulnerable women would be eligible for extended gestation period for termination of pregnancy. So it means that not all women would be allowed termination of pregnancy from 20 to 24 weeks by opinion of 2 RMPs. There is a certain group of women who would be allowed, which have been defined. And also norms for the registered medical practitioner have also been defined, though they are almost the same as previous one, but now the training for medical abortion has become shorter, because medical abortion can be performed by with less experience also, plus the basic knowledge has to be there. And of course, we have the medical boards for abortion after 20 weeks in cases where the fetus is anomalous. So what are these special category of women? Survival of sexual assault, rape, incest. So they can be allowed between 20 to 24 weeks. Women with pregnancy in humanitarian settings. What does that mean? Like we had COVID, there were women who were not able to move from their place of work if there's a drought or something, and woman is not able to come to the facility, then she would be allowed. If when she is pregnant, there's a change in marital status. Either she becomes a widow or she takes a divorce. That is also a ground for seeking abortion between 20 to 24 weeks. Women with physical disability, as defined under the Disability Act. Mentally ill women, including mentally retarded women, minors, and if the fetus has substantial abnormalities, as we have talked about earlier. So RMP, we all know, I think it is not much change in the surgical abortion criteria for RMP. Our medical practitioner who has assisted in 20 cases of MTP, of which at least 5 are done independently. Medical practitioner who has completed 6 months of house surgery in obs and gynae. Medical practitioners who hold a postgraduate degree or diploma in obs gynae, or a medical practitioners having experience of at least 1 year in the practice of obstetrics, 1 RMP opinion up to 20 weeks, 2 RMP 20 to 24 weeks, and beyond that, a medical board has to be set in. An additional qualification for medical method is, which is little less than what we require for a surgical method, an RMP who has experience in the practice of obs and gynae in any hospital for 3 months, or has a training of performance of 10 cases of medical method under supervision of a RMP in a hospital, or a training institute which is approved for the purpose of medical method of abortion. So the training has become much less, so that more people can perform medical method of abortion instead of, patients going elsewhere. So again, just to recapitulate, till 9 weeks, experience and training requirement for RMP is experience at any hospital for 3 months in the practice of obs and gynae, or independent performance of 10 cases of MTP by medical method under supervision of a RMP in a hospital established or maintained or training institute approved for this purpose by the government. A practitioner who has assisted a RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently. This is for surgical method. A postgraduate, like we said earlier, for surgical method, a practitioner who has done 6 months of house surgery, or somebody who's worked for 1 year in a obs and gynae, and only one person can decide to do it on their own. Between till 12 weeks, again, we require somebody who has, because medical method of termination is only allowed up to 9 weeks. So beyond that, you have to have the same criteria of 25 cases, 5 independently, postgraduate degree or diploma, or 6 months house job, or 1 year practice in obs and gynae. It's only till 9 weeks when you can do medical method also. And for medical method, we have decreased the experience and training. Beyond 12 weeks till 20 weeks, person who has a postgraduate degree or diploma, 6 months of house job, or 1 year of working in a Obs and Gynae department, and single person's opinion is required. And for between 20 to 24 weeks, same criteria, but you require the opinion of 2 RMPs. In this, we don't have that 25 cases criteria. They can only perform up to 20 weeks, but a postgraduate, a house surgeon after 6 months, or a practitioner after 1 year in Obs and Gynae department can do. So this is the difference between 20 to 24 and less than 20 weeks from 12 to 20 weeks. That just having done 25 MTPs and 5 independently does not make you eligible to perform the abortion between 20 to 24 weeks. And beyond 24 weeks, we have to have at least a postgraduate degree or diploma, or you have to have worked for 1 year. And the house surgeon for 6 months cannot. And of course, opinion is medical board is required. And when medical board says that it can be done using all safety precautions at an approved place after appropriate counseling, then only it can be done. What will constitute a medical board? Just been defined that a gynecologist, a pediatrician, a radiologist have to be part of it. And it has been suggested that wherever the abortion is being performed, the HOD of that place, a lady gynecologist, should be part of it. And if the anomaly is such that we feel that we require the consultation from a cardiologist or a nephrologist or a urologist or a neurosurgeon, they have to be part of the team. And also the chair of the medical board have the power to replace a person who cannot come. For somebody says they have committed to come for the board and she doesn't come, then he has the power to replace that person and not postpone the date of the medical board. So what are the powers of medical board? To allow or deny termination of pregnancy beyond 24-week gestation only after due consideration and ensuring that the procedure would be safe for the woman at that gestational age. And also the malformation has substantial risk of it being incompatible with life, or the child born would suffer from such physical or mental abnormality to be seriously handicapped. And of course, like I said, the other specialist can be co-opted. This medical board formation is in process. In Delhi, we have up to now only probably All India Institute and Maulana Azad, where these boards are already in place, but government is asking for support from FOXI as well as WHO that more boards are formed so that it becomes easy for everybody. And the function is, of course, to examine the woman and her reports who approaches for medical termination of pregnancy, and then provide the opinion on a Form D with regard to termination of pregnancy, whether it is rejected the request or acceded to the request. And they also have to ensure that the procedure, if advised by the medical board, is carried out with the all safety precaution along with appropriate counseling within 5 days of receipt of the request of medical termination of pregnancy. And the board has to respond within 3 days what is their opinion, so that not much time is wasted. So that is what I had to tell about the new amendments. And any queries regarding the new amendments are, you can ask now. Monica will tell me the questions and we will be answering. And of course, after you finish the training, you have to fill up a form, post-test form, before you would be, entitled to get a certificate. So that is all about this amendments. And if there are any questions, you can put in chat box instead of asking directly, because at the moment I don't see any question. Monica, are there any questions?
No, ma'am, not as of now.
So anyway, if the question comes to somebody's mind later, we can take it up after the next session. So the next session is about, the technicality of the methods of medical abortion, the drugs for medical abortion. And for that, we have a very learned professor, Professor Anuradha Singh, who is a professor in Lady Hardinge Medical College. And she is going to update you about this technology of abortion. So over to you, Anuradha.
Thank you so much, ma'am. Dr. Achla, is my screen visible?
Yeah.
Yes, it is.
Thank you, Team AOGD, Dr. Achla, Dr. Monica, for giving me this opportunity to talk about safe abortion updates in technology. And
Sorry to
now,
interrupt you. Madam, it's not full screen, madam. It's still in
okay,
PPT.
yeah, I'm doing that. Just a moment.
And your video also.
Yes, ma'am. This. Okay, am I visible? And my screen is visible, I guess. Hello, ma'am. Hello, Sharda, ma'am. Good to see you here. And we'll start with our safe abortion updates in technology. Now is the era. Yes, ma'am. Anything?
No, actually, because of today's event, actually, I had planned that Dr. Sharda would say something before I start, but it just went haywire. Dr. Sharda, you want to say something about the program? Because like you said, we all went numb, and so, Madam.
I think the program design is absolutely great, because I'm glad that you started with the new MTP Act and how it is different from the past this thing, and what are the amendments. I think very beautifully taken, and I think it does not leave any questions after listening you. And then we will hear from Professor from Lady Hardinge Medical College that what are the safe abortion techniques are available. And then I think the counseling part is also very, very important. So these 4 aspects which you have designed it along with the WHO and the FOXI and the AOGD have joined hands together to give this particular program. And I think each one of us should be absolutely competent to give respectable safe abortion, not only safe abortion, respectable safe abortion, and that is the need of the hour. And I think, if you want to cut down on maternal mortality, this end of abortion, I think has to be well taken care. I think doctor has made it very, very clear what confidentiality means. Dr. Achla had been absolutely crystal clear at every step. Now, what all things have to be confidential. As for the discharge slip name is concerned, I think she's made it also very clear. On a discharge slip, she can have a name for herself. So I think I'm looking forward attending the whole session along with everybody else.
And there were a few more things which I had to say, like my mind went up, I wanted to share that this is the program. I've done 2 more, but this is the program we have found the audience so enthusiastic that instead of my urging them to attend, they were asking for the link. And because of some technical glitch, the link was delayed. And the other important thing about this program is that Dr. Sharda has attended as a participant. When I was asked to send names of master trainers, I think Dr. Sharda, you remember I'd asked you, and you said you will give me full support, but with all the things which you have, you'll not be able to do the trainings, but you said my wholehearted support is with you. So that is why I wanted to bring it out that you have always supported the cause of the woman. And today, by attending as a participant, so that you know what is happening, you are able to support the cause of the woman and support this movement of respectful abortion care. So I'm really grateful to you. And I think FOXI should also be grateful to you for you attending as a participant when, I would say that you're not a participant, you are a guest of honor for
Thank you so much.
AOGD and
Thank you so much, ma'am.
So all these things, just went out of my mind with that news. So, but I wanted to share.
Thank you so much.
So Anuradha, you
Yes.
can.
Yes, ma'am. Very rightly said. Your opinion will be really valuable to us, Sharda ma'am. And it's great to have this WHO FOXI initiative. And now is the era to move from respectful maternity care to respectful abortion care. We cannot forget the respectful abortion care. It is an essential part. And our ministry also is trying hard to put up this respectful abortion care at all levels. And we expect to provide abortion services even at the peripheral health centers, even at the maternity homes. In fact, a few months back, we conducted a training of the maternity homes under Dr. Bimlesh from ministry, and it was a very successful program. And of course, the enthusiasm was great. So without wasting much time, we'll start with safe abortion updates in technology. The session overview will be, we'll talk about the existing guidelines regarding how to provide abortion. We have something to talk about pre-abortion assessments, the medical methods and the surgical methods. I'm sure all of you must be aware of these because I'll be mainly talking about the first trimester abortion techniques. And I'm sure you must be aware of these techniques, but it is always a good thing to revise all the guidelines. So WHO has moved on from releasing so many manuals on safer updates and safer abortion technologies regarding medical methods of abortion, and all these manuals are available online. And in fact, our government is not left behind, and we had a historic achievement which ma'am has already talked regarding the MTP Amendment Act 2021, which also emphasize on comprehensive care as it is mandated by law. So all the guidelines across the WHO or the Indian guidelines we talk about three main important things. First is the pre-abortion care, which starts from the detailed assessment and investigations if required. What are the methods we have available, and what is the aftercare and follow-up, including post-abortion contraception and counseling, which will be dealt by the next speaker. So whenever a client, we do not call them patients, we call them clients. So whenever the client for an abortion comes to us, we need to have a thorough assessment of the patient. Now, remembering from our old MBBS days, the assessment includes a detailed history taking, the general physical and pelvic examinations, lab investigations if required, not mandatory, and decision-making information on abortion, the procedures, and counseling. Now, when we talk of history starts from the basic things like the age, which is essential. Suppose she's a teenage pregnancy, so her concerns will be little different. What about the religion, which can have a psychosocial impact on the abortion care we give, and the address, of course, for the records. Menstrual history is essential to know the correct dating, the length and the duration of the cycle flow, whether it is excess or normal, and when was the last menstrual period. Obstetric history, what parity, how many live births she had, how many abortions she had, whether it was an induced or a spontaneous abortion, whether there is any history of previous cesarean section, because there can be complications associated while we are performing the procedure, the last childbirth or the last abortion she had, and whether she is presently lactating or not, because that will hamper her menstrual cycle and the accurate dating. And we should always never forget to ask any history of any interference or the drug being taken in this pregnancy to attempt termination, because majority of the women, they try to hide all the histories that they have taken a MTP pill from a chemist or something like that. So the management actually changed. So it is very essential to deliberate upon these points, like any history of any interference. Contraceptive history is essential because we are talking about pre and post-abortion. We are talking about contraceptive counseling throughout the abortion process, which starts from the pre-abortion assessment. Tetanus immunization is essential if we are planning for a surgical evacuation. Psychosocial assessment is very, very important. We have started this program with a sad news, and that is why the importance of psychosocial assessment of a client is very essential. And we have to assess whether what kind of family support she has, why she has come to our facility for abortion, why she wanted an abortion, whether she is a rape victim or she's a victim of sexual abuse. I think all these history are very, very essential to provide an additional support to the patient, and the patient will have confidence in us. There's a history of sexual assault or domestic violence, which we need to ask if the patient is willing to disclose that. Then history of pre-existing medical and surgical conditions is essential, like hypertension, diabetes, heart disease, asthma, epilepsy, which we routinely ask, or any other previous or uterine and abdominal surgery is essential, because then if we are doing a medical abortion by drugs, then some certain drugs may have contraindications or special precautions when we are talking about this chronic illnesses. General physical examination, vitals, of course, we have to look for anemia, jaundice, edema. See, it is an elective procedure. Unless and until it is a life-threatening procedure, a thorough evaluation is a must. We are not in a hurry. Of course, we are not in a hurry, so we should we should have a careful watch for vitals. We should look for anemia, jaundice, edema, lymphadenopathy, any thorough examination starting from head to toe, any abdominal examination for masses if we are planning a surgical evacuation, and a simultaneous ligation for the patient. So abdomen for masses and tenderness, examine the cardiovascular and the respiratory examination is a must. Gestational age assessment is accurately done if the LMP or the last menstrual period is known, and we know that we have to divide it by the number of days from the last menstrual period has to be divided by 7. Then this will give us the weeks of gestation. For example, 49 days from the LMP will mean 7 weeks of gestation. And if LMP is not known, and suppose the patient is in lactational amenorrhea, then a careful bimanual pelvic examination will give you clue regarding the approximate period of gestation. And I again remind you that ultrasound is not mandatory, but if you have a facility and you are in doubt, please don't hesitate in doing a scan. But it is not mandatory. If you do not have a facility and you are very sure about the dating and your clinical pelvic examination, then it is not essential. And now this figures basically give you the basic teaching of obs and gynecology, like at 12 weeks, uterus becomes a pelvic organ. It arises out of the pelvis. At 16 weeks, it is somewhere between the umbilicus and the symphysis pubis. At 20 weeks, it is just below the umbilicus. And after that, the fundal height, usually in centimeters, corresponds to the period of gestation in weeks above the symphysis pubis. And a very common viva question, which we routinely ask in our MBBS days, like, a uterus may be smaller than the period of gestation. Then what can be the reason? It can be the woman is not at all pregnant. You have not done a UPT, so please try doing a urine pregnancy test. She may have an inaccurate menstrual dating. She may be having an ectopic pregnancy. And the limitations to the uterine size by physical examinations are there in certain conditions, like there are uterine malformations, the fibroids, the woman is carrying a multiple gestation, there is a marked uterine retroversion, so you are not able to assess the fundus of the uterus. There's obesity and there's a molar pregnancy. Of course, when the uterine size is more than the period of gestation, then the reasons can be many. It can be fibroids, it can be multiple pregnancy, it can be molar pregnancy. So if you are in doubt, try getting a scan. Routine lab tests as per the guidelines is not a prerequisite, but in our center, we are getting a hemoglobin and a urine albumin sugar done. So it is prudent to get at least hemoglobin done if you have a facility. Otherwise, you can go on your clinical examination. And the test that may be performed as per the individual risk factors which are there present on your history and examination, like pregnancy test. If you feel that the uterus is almost normal size and the lady says, I'm pregnant, hemoglobin or hematocrit for suspected anemia, RH testing if available, HIV testing and counseling. If you feel that the woman is coming she's a victim of sexual abuse, or she is working in some, basically she's a sex worker. So HIV testing and counseling, or her partner is a high risk. STI screening, of course, majority of it can be done on a routine examination. Laboratory test may be indicated. Suppose she has a history of chronic disease like chronic hypertension, then you would of course like to get a kidney function test and a basic evaluation done before considering her for abortion services. Ultrasound, as I said, is not mandatory unless and until you are in doubt. Now, there are certain components of pre-abortion counseling. We have to ask the client, what about her thoughts about terminating the pregnancy? What is the reason for terminating the pregnancy? To provide her the additional support if required. Inform her that early abortion, if basically performed as early, it is safe. You have to get it done in the hands of a trained provider at a safer place. Give her the options available. Suppose she is 7 weeks pregnancy, you can give her the option of medical methods, you can give her the option of surgical methods, whichever she chooses. And the risk and warning signs associated with the, suppose she chooses a surgical method, then you have to counsel about the procedure, the steps, the warning signs. And of course, which I feel is the most important thing in providing an abortion care is that we always forget not to forget to tell the lady that she can get pregnant as early as within 10 days of a first trimester abortion if she is not using an effective contraception. So the right time to use the contraception is now. This is the most important information which I feel was lacking when I started my family planning as a nodal officer. I could see and says that majority of the women are not aware of this fact that they can get pregnant as early as 10 days or 2 weeks after a second trimester abortion. So this is a very important information, and majority of the women, they at least make their minds about some kind of contraception. and give her the information about the resumption of normal activities, because it is a OPD procedure or it is just a daycare procedure. So how soon she can resume her normal activities, how soon she can have a sexual intercourse. I think this is equally important. Any other follow-up care which is required as per the procedure. And documentation is mandatory. As Ma'am said, there are various forms which need to be kept at every center which is doing a MTP. Even if now the word of respectful abortion care comes here again, that it is a choice. So even if she is not willing to take up any contraception, she should be provided with abortion services. And now, certain important counseling tips which I feel are important, that the counseling which goes in the process of abortion has to be non-judgmental. It has to be an empathetic counseling, and should be provided it like a continuum through before the procedure, during the procedure, after the procedure. You should be an active listener. There should be an open-ended questions, and there should be a lot of verbal and non-verbal communication which goes and makes the patient comfortable, and she opens up to you, and she opens up about the discussion of contraception, because it is a very personal issue. Now, when we come to the actual abortion methods, as per the recommendations, the abortions can be divided into first trimester and second trimester. In the first trimester, the medical abortions, as per the GOI recommendations, are given up to 9 weeks only. And after 9 to 12 weeks, between 9 to 12 weeks, it is more of a surgical abortion. But the global recommendation is that in the first trimester, both medical and surgical abortions can be taken. But of course, we are a citizen of this country, so we respect the Government of India guidelines, and we at our center are providing medical abortion only up to 9 weeks. More than 12 weeks, they say that you can use a medical abortion, which we are doing that. It is a second trimester abortion. Dilatation and evacuation is usually not preferred. And when it is a dilatation and curettage, it is not a sharp curettage which is to be done. Now we talk about the first methods of first trimester abortion. It can be medical and surgical. I hope all of you are aware. Surgical can be done by a manual vacuum aspirator syringe or an Mba syringe or an electronic vacuum aspiration or the routine suction evacuation, which you know. Now, when we talk of medical abortions, we give 2 tablets. One is tablet mifepristone and tablet Mesoprostol. Mifepristone is basically an anti-progestin, and it inhibits the action of progesterone. So it interferes with the continuation of pregnancy. And the initial oral dose of mifepristone is followed by the Mesoprostol, which is a prostaglandin E1 analog, and it causes cervical softening, uterine contractions, and ultimately the expulsion of production. Now, this Mesoprostol has certain advantage. It is a PGE1 analog. It causes strong uterine contractions. It is available in various strengths, but we usually use only 400 or 800 microgram of strength. And the advantage is that, especially in the primary healthcare centers where we do not have a facility of which this Mesoprostol can be kept at room temperature. And the most important thing, that it is well absorbed from different routes of administration. Now, talking about this medical abortion in detail, you have 3 visits which are planned up. So day 1 visit, I'm talking about medical methods of abortion now. So on day 1, we give a mifepristone, which is 200 milligram oral dose, and anti-D if the woman is Rh negative, 50 microgram as per the recommendation. On day 3, so woman is called after 48 hours. And on day 3, up to 7 weeks, we usually give 400 microgram of Mesoprostol. The route can be any. That means it can be sublingual, it can be buccal, it can be vaginal, or it can be oral, depending upon the patient comfort. But we need to explain the certain side effects which is associated with each route. Between the 7 to 9 weeks, it is 800 microgram of Mesoprostol. In addition, we should never forget to give analgesics, antiemetics if required, and of course the contraception, which will be talked in detail in the next session. Now the lady is usually called on day 15 after that, and majority of the times, in 97 to 98% of the times, the abortion is complete. We should confirm and ensure the completion of procedure, do an examination to evaluate whether the abortion is complete or not. And again, we can talk about contraception if already not done so. Now, when we talk about different routes of Mesoprostol, we are preferring a vaginal route because, as you can see in the slide, in oral route, in buccal route, and in sublingual route, there can be fever, there can be chills, there can be nausea, and there can be vomiting, but not to every patient. If the patient is not preferring a vaginal route, she should be given an oral buccal or a sublingual route, whatever she prefers. In the vaginal route, the pills are placed in the vaginal fornices in the deepest portions of the vagina, and the woman is instructed to lie down for 30 minutes. It has the lowest rate of side effects. In the sublingual route, it is placed under the tongue and swallowed after 30 minutes. In the buccal route, it is placed between the gums and the cheek and swallowed after 30 minutes. And orally, it can be just swallowed with a water. Now, this is a picture which shows you the buccal, where we can see the between the cheek and the gums, the tablets are there. This is the sublingual, which is the tablets are seen under the tongue. These medical methods of abortion, our ministry is also trying hard to start these medical methods of abortion at the maternity home center. So they are in the process of procuring the MMA drugs at maternity health centers. And they ideally, the service can be provided at a primary care level, but with a referral system in place if it is required, and women should know where to go in case of complications, where she should be referred. Additional services which may be provided to the individual seeking medical abortions, like counseling for STIs, we have already talked about it. Abuse support services, that is why the psychosocial stress or psychosocial history evaluation is important. And other specialists or medical services, suppose she's a hypertensive or she's a diabetic, then we need to give her a continued medical care. Provide iron tablets if she is anemic, any necessary pain medications, and of course the emotional support, because we are talking about respectful abortion care. Now, as per the latest guidelines, the follow-up routine is not necessary following an uncomplicated medical abortion using mifepristone and mesoprostol. A follow-up visit at 7 to 14 days after the procedure may be offered to the patient to provide a contraceptive counseling if she has not opted for, any emotional support if she desires, or address any medical concerns. But it has been recommended that a routine follow-up visit is recommended only in cases of medical abortion using mesoprostol alone. But as per the Government of India guidelines, we are following a MIFI and a meso combination. So we do call our patients for follow-up and provide them a regular checklist to have. Now, the follow-up care, whenever the patient is coming to follow up at 3rd day or at the 15th day, we should assess the woman's recovery, ask her for any signs and symptoms of ongoing pregnancy, like she has a continued vomiting or nausea of pregnancy, review any available medical reports and referral documents if she has, ask about the symptoms experienced since the procedure, any danger signs which might be there, perform a focused physical examination for any complaints, like she is saying, I'm still bleeding. So you need to have a local examination done, assess the women's fertility goal and need for the contraceptive services if not provided earlier. Now, this is a routine MMA or a medical methods of abortion card, which is given from the Government of India to the clients which are coming to the facility for having a medical methods of abortion. It basically gives you the danger signs. It gives you the normal signs which may be there at the time of abortion, like it says in Hindi, Sadharan Mahabari, pet mein dard ya ethan. See, you can't scare off a patient. You have to tell them that these symptoms are normal. You may expect a little bleeding or passage of fleshy mass. You may expect a little basically spasmodic pain in the process of expulsion. You may have a little bit of diarrhea or a fever and a mild headache. But if the symptoms worsen, like she had a continued bleeding for 2 hours, she's using more than 2 pads in the first 2 hours, or she has taken Mifi and Meso and she has not bled for the last 24 hours, and she has pus discharge or foul smelling discharge, and she had a high grade fever which is not subsiding, then she needs to report to the hospital. I think this is a very beautiful card and a follow-up with the symptoms mentioned. Now, to summarize the medical methods of abortion, on day 1, we have a detailed assessment, including the dating. We give her a mifepristone and an anti-D, mifepristone 200 milligram oral. We ask the women to return for mesoprostol after 2 days. Contact address and facility, phone number of the facility of the referral center is essential to give her in case of an emergency. And record her experience of any side effects on the MMA card. 3% of the women, they say they can abort with a single dose of mifepristone only. On the second visit, that is on day 3, we give her a mesoprostol, 400 microgram if she is less than 7 weeks, or 800 microgram if she is between 7 to 9 weeks. And we give her analgesics. We again give her the contraceptive options, because majority of the contraceptive options like hormonal methods, oral or injectable, can be started on day 3. Of course, you cannot put in an IUCD or you cannot do a ligation, but you can offer her DMPA injection, which is freely available, and the woman may be susceptible at this point of time to receive some form of contraceptive option. Tell the women that mean period of bleeding is usually the period bleeding. This bleeding of this the first trimester abortion does not last for more than 2 weeks, but sometimes the spotting can go on up to a month also. These are the possible side effects, which can be mild in nature. She has to report in case of excessive bleeding, and she has to report if there is no bleeding even after Mesoprostol administration, even after 24 hours. And 75% of the women abort within 4 to 6 hours of Mesoprostol administration. Now, on the third visit on day 15, we need to do a pelvic examination. Again, we have to offer her some form of contraception. Of course, IUCD only after surety that we have completed the procedure is complete and there is no retained products and there is no evidence of infection. And the ligation can be done can be done only in the next cycle. It cannot be done on the day 15. And tell the women about the immediate return to the facility, and she has to report back if she does not have periods within 6 weeks of the completion of the process. An ultrasound may be done if you are in doubt. Now we have certain side effects and complications to talk about. Pain, nausea, vomiting, diarrhea, and infection. Pain is usually more of a psychological factor, so we have to be respectful, we have to be non-judgmental, we have to give her a verbal assurance, keep talking to her during the procedure, keep counseling her, give her a painkiller if required, like Brufen 400 milligram. If there is a persistent pain, think of some drugs, because the woman has to be comfortable. If she is not really with painkiller and there is a persistent continuous pain, or she has a fainting attack, think of ectopic pregnancy, think of infection. Nausea and vomiting, usually because of drugs, are self-limiting. We just have to reassure them. Diarrhea, maybe within a day or so, 2, it settles. And infection can be confirmed by the physical examination. And after that, the action for failure and incomplete reason. Sorry, this is for the, what are the other complications we can have, like failure of medical method of abortion. So what we can do, we can offer her a surgical evacuation, or we can do a repeat medical method of abortion, of course, under supervision. If the abortion is incomplete, we have to observe unless and until she bleeds heavily. And if she is not bleeding heavily, the uterine size is normal, then abortion is usually complete. And if the heavy bleeding continues, then we have to offer her surgical evacuation, do an ultrasound. And in cases of incomplete abortion also, we can offer a repeat dose of Mesoprostol. Now, in case of excessive bleeding PV, how will the patient present that I had excessive bleeding PV? She'll say that I have bleeding which is usually more than her menstrual cycle. You have to tell her that this is the excessive bleeding. Soaking 2 pads in 1 hour for 2 consecutive hours. And if the bleeding decreases over time during the 15 days follow-up, we just have to observe her. We have to do a little examination. If she is complaining of heavy bleeding, the POCs might be lying in the cervical canal. There is a ballooning of the cervix. We just have to do a simple digital evacuation, observe the woman. If she is stable, then we have to we can just send her home after keeping her under observation for a few hours. And if the bleeding continues, even after your digital evacuation, then you need to have an ultrasound done to be sure that you are not dealing with any retained products. If it is a minimal decidual bit on ultrasound, you just have to wait and watch. The Mesoprostol may take a little longer, or Mifepristol may take a little longer to have its effects. If there are POCs and decidual bits, if the woman is not excessively bleeding, you usually do not resort to a surgical evacuation. If the ultrasound shows a POC and a decidual bits, what you can do is just give her a Misoprostol 600 microgram oral or 400 microgram sublingual. And if it is failed, you simply see a sac there, which was there earlier before. It is a failed MMA, and you can just offer her a suction evacuation. Now, recording and reporting for MMA is same as per any other MTP procedure. We have to fill the Form C consent form, Form 1 RMP form, Form 2 from your facilities, which goes to the state level for monthly reporting form, and Form 3 is the admission register. Now, these are the various forms. This is Form C, which is the consent form. You can see that the woman has to be more than 18 years to give consent. If she is less than 18 years, or she is mentally ill person, or she is a minor, you have to take a consent from the legal guardian. This is an opinion form which is there, which basically gives the information regarding the registered medical practitioner. We have already known that up to 20 weeks, only one medical practitioner opinion is required. And after 20 to 24 weeks, it is a 2 medical practitioner opinion which is required. Now, in the last column, you can see 1, 2, 3, 4, 5. These are the reasons for MTP. And it is very essential to usually tick these reasons once you are filling the MTP form. This is a monthly reporting form which usually goes from each facility to the state level. And this is the admission register. Now, this admission register, as ma'am has said, that confidentiality has to be ensured. So you have to be, this admission register has to be kept under lock and key, because it is the only place in a facility where the details of a patient seeking an MTP can be kept. You cannot disclose the other details of the person in any other part of your facility apart from this admission register. Now we have talked about medical methods of abortions. Now let us talk about the first trimester surgical methods of abortion. I'm sure you must be doing it and you must be aware that we have 2 methods. Either we have the MVA, manual vacuum aspiration, or the electronic vacuum aspiration. Surgical abortions are usually recommended up to 12 weeks. We have talked about that. And medical up to 9 weeks. Between 9 to 12 weeks at our center, we are doing a surgical abortion. And WHO recommends manual vacuum aspiration as the safest method. And the procedure should not be completed by a sharp curettage. So sharp curettage is not mandatory if you are sure with your suction evacuation methods or the manual vacuum evacuation methods that the uterus is empty. Now, I'm sure all of you must be familiar with this figure, which gives the detailed parts of the Mba syringe. And I hope that in the subsequent trainings, we have a physical session. So this can be little hands-on about this Mba syringes, because we usually tell our postgraduates and residents and we give them a hands-on session to operate this Mba syringe. And it is very helpful and it is very, very simple. I think it can be done at any place. And of course, certified. And cannula is attached. We have the Commons cannula, which is there. And the size of the Commons cannula is according to the period of gestation. Suppose a 8 mm cannula for 8 weeks and a 10 mm cannula for 10 weeks. So we have this is the picture of the cannula and this is the picture of the Mba syringe. Now this figure basically tells you the various parts of the Mba syringe, how to dismantle it for cleaning is essential. The training is also essential for that. And I'm sure physical training will help more in telling you the parts of this Mba syringe in detail. Now, all of you must be familiar with this figure also. All of you must be having this suction machine at your facility if you are doing an MTPs. It is an electric pump is used to generate a vacuum, and this vacuum is used for MTPs, surgical MTPs. Now, cervical priming usually helps in surgical MTPs, and it may be considered in a women with a pregnancy of any gestational age to prepare the cervix and to make it soft. What are the recommended methods of cervical preparation in the first trimester? Either we can give oral Mesoprostol, or we can keep Mesoprostol 400 micrograms sublingually or vaginally 2 to 3 hours prior to the procedure. Laminaria tent, we are not using it right now. So we can give Mesoprostol 2-3 hours before the procedure. It really softens the cervix and you don't have to force your cannula inside, because that can cause injury, especially in a nulliparous lady or a previous any lady who has a cervical injury on the cervix or the previous surgeries on the cervix. The cervix usually become fibrosed and it may not easily give way. So you can end up with a perforation or making a false tract inside the uterine cavity. So it is always prudent to use these the cervical preparation methods if available. For pain, pain can be because of physical problems or it can be because of anxiety. Like we have 2 components for these pain management. Accordingly, we have the non-pharmacological and the pharmacological. Non-pharmacological, of course, we have talked about it has to be a respectful care. We have to provide a psychosocial support. We have to perform the procedure gently and smoothly. Suppose we are doing it under local anesthesia, keep talking to the patient, make her relaxed, keep her aware what is happening. Now the procedure is complete. It is a very simple procedure. Don't be in a panic. So we have to keep talking to our patient. And of course, if you need a pharmacological method, for reducing the anxiety, it can be as detailed in this table. We can use anxiolytics, maybe a GA, but usually we are not doing that unless and until patient is very apprehensive or it is a difficult procedure we expect. Then cervical dilatation, which usually causes pain in a surgical MTP. It is the main cause of pain, it is the main cause of pain in the surgical abortions. So we can either use a lignocaine or a local anesthesia, or we can use a brufen at least 1 hour prior to the procedure. The local anesthesia is usually given 10 ml of 1% lignocaine, and the duration of effect is somewhere between 1 to 1.5 hours, and it is very effective. You have to actually wait for some time to start the procedure after you give a local anesthesia. You have to wait for 5 to 10 minutes. It is not immediately active. So that is the most important thing. And for uterine cramping, you can give oral analgesics. Now, for the steps of MBA, this picture actually shows the MBA syringe. If you can just look into the picture, there are two valves on either side of an MBA syringe. You have to close these valves, pull the plunger behind, and create a vacuum. This is called as a charging of the instrument. Step 2 is ensure the pain control and ask the woman to empty her bladder. Step 3 is perform an antiseptic cleaning of the cervix. It has to be in a mounted, probably a betadine, in a mounted sponge holder, and it has to be in a circular manner without touching the vaginal walls, because that may contaminate the sponge. And administer the paracervical block. It has to be given at the junction of the cervix and the vagina, apart from 3 and 9. It is not to be given at 3 and 9 o'clock, because there we have the descending cervical branches of the uterine artery. So barring 3 and 9 o'clock, it can be given at 2 and 10 o'clock. It can be given at 4 and 8 o'clock. It has to be given at the junction of the cervix and the vagina in the fornices. And you have to keep withdrawing the local anesthetic, keep injecting and withdrawing it simultaneously, not more than 2 to 4 ml at each side, at both the sides. Then you insert the cannula, dilate the cervix and insert the cannula. Withdraw the cannula at least 2 centimeters below the fundus and keep rotating the cannula till you see the contents in the syringes, and then gently release the vacuum button on the aspirator. And you can see the product flowing into the syringe. See, it is also important to note what are you doing. You can actually see the products inside the syringe. If you cannot see the product, suppose you are evacuating a 9 to a 10 weeks uterus and you cannot see the products, that means you are in some wrong place. You need to recheck your procedure. Since the patient is under anesthesia, you can very well reattempt it. But if you are not able to get any products, you at least you are able to check that I am in the wrong place. Now, signs when the uterus is empty, it is a foam, red or a pink foam, which comes inside the cannula. It has the cannula has a gritty sensation when you are doing a curettage inside the uterus. The cervix usually grips the cannula, and the movement of the cannula is difficult, and the uterus contracts around the cannula. After that, you really need to inspect the tissues of the surgical evacuation. You have to perform a concurrent procedure like an IUCD insertion, whatever the lady has consented for, or a sterilization. And of course, the disinfection of the instrument comes in the last, but it is the most important. So to summarize, it is a safe technology. Both manual and electronic vacuum aspiration is safe technology up to 12 weeks. Accurate clinical assessment is must, and informed consent should be there. Ideal pain control, in our setup, we are using a local anesthesia and an oral analgesic primarily 1 hour before, and should be performed as per the protocol, as per the guidelines. These guidelines are freely available in the net. Please go through that. And follow-up visit should take place within 1 to 2 weeks of the procedure. Now, the post-procedure care is essential. You have to observe the lady for 3 to 4 hours, unless and until she is comfortable to go home. She is not bleeding excessively. Her vital signs are absolutely normal. You have to document all the findings, give her all the necessary document and the information and the discharge card. Keep her aware about the danger signs for which she has to follow up in the emergency. You have to manage the complications as briefed before in the previous slides. And as said, no routine follow-up unless meso alone regimen is used is newly recommended. But we do call our medical methods of abortion patients and surgical evacuation patients for follow-up. So to conclude, I would say that India has made a historic progress, but not much has actually changed in the technological update. We have been actually using all these technologies for many, many years now. The most important thing is to ensure safety and quality and provide a respectful abortion care, I would say again. Thank you so much. Thank you for patient listening.
Thank you, Anuradha, for a very nice update and very crisp. And I think you have made the things very clear with the small information about, that patient has to be informed that within 14 days, after 14 days, she can become pregnant. A very important point which has to be told to the patient. And The rest of the things, of course, it is just a revision of, you all know, it's always good to have a revision, especially about medical methods, surgical, we all are performing, and the MVA, it had become very, very popular earlier because till 9 weeks, it was very safe. But now with the medical method of abortions available for up to 9 weeks, not much use of MVA is being done. But I suggest that wherever there's a small setup and you want to do a surgical method, I think MVA is much better than the surgical method because the chances of complications are much less. And even if there's a perforation, there wouldn't be much harm done to the patient, because as soon as there's a perforation, the pressure falls down and nothing will come into the uterus.
Exactly.
But in electrical suction, if you do a perforation, you may not know, and you can have suck-in intestine or something. And we still do get such patients, but with MVA, as soon as there's a perforation, you will know that the pressure is lost and you have. So very well presented, Anuradha. And Monica, are there any questions in the chat box? Whatever questions are there, even if they have been answered, I would like them to be repeated so that everybody knows if they have not read in the chat box. Monica?
A question has been posted. Any need to get a check ultrasound for complete evacuation before going for IUD insertion?
No, I don't think so. Because their physical examination will tell you so many things. Even if you are performing a surgical evacuation, you do a repeat, you get that signs of completion, as I said, that the os starts dripping over the cannula, you get a red or a pink frothy foam inside the cannula, and you are sure that you have not left anything inside the uterine cavity. And after that, you perform a routine per vaginum examination. And if the uterus is a little bit contracted, suppose it was a 10-week size, now of course, it will not become a normal size immediately, but it will be well contracted and firm like a ball. And you can actually make out that there is a difference between the initial size and the final size of the uterus. And os usually gets closed as the procedure is complete. And similarly is the thing with the medical method of abortion. If the patient is coming for follow-up, a good physical examination and a good history will give you a clue that your procedure is complete. If any doubt, of course, it is always better to perform an ultrasound. It is not mandatory. It is not mandatory if you are sure.
Yeah. So the next question is, what is your advice? Should the products be sent for histopathology after each MTP? In medical legal cases, it has to be done or sent, and you have to write the name of the patient in the form.
Yes, I would suggest if the abortion is being done in a hospital setting, we usually send the products for histopathology, of course, because medical method is an OPD procedure and the patient is at home. So, of course, we cannot send the products for histopathology, but it is always good if you are performing a surgical evacuation. Suppose in MLC cases, you do get MTPs for MLC cases in your hospital. So it is always good to send the product for histopathology.
But the second part of the question, that the we've already said confidentiality is to be maintained for the woman's dignity, respect. But if it is a medical legal case, and if by law we are required to expose the name of the patient, that has to be done. We cannot go against law. It is very clearly written in the amendments that if not required by law, then keep it confidential.
Yes,
but
yes.
for the law, we have to write the name.
We have to try as far as possible to keep the confidentiality in place. In your centers, in our centers, we are trying that. We have only one register where the details of the patient are mentioned, and rest of the things, it is the number which circulates in the files. We do not disclose any patient's name, and the discharge card is, of course, with the patient, as ma'am has already mentioned. So there is no question of leakage of secrecy of the patient.
I would further request the participants to please, keep putting the questions in the chat box, because as per the format of the training, we would not allow as such, unmuting you within the program. So you can put your questions in the chat box rather than raising hands. Okay, another question is, if a patient comes with UPT positive even before missed period for MTP, what is supposed to be done?
First you have to take a detailed history regarding her previous menstrual cycles. What was the length of her previous cycle? Whether her previous, which she says is a normal cycle, could be having a less period or just spotting only, and she has missed noting the details of her previous cycle. So she may have conceived in the previous cycle only. And you can get an idea about the period of gestation by doing a physical examination. As I said, that the period, as the uterus grows, you can actually make out how many week sizes the uterus on physical examination. And if in doubt, it has already been said that you need to do an ultrasound. If in doubt, that whether you are dealing with an ectopic pregnancy or you are dealing with a mistaken dates, because you need to give the accurate method to the patient, or the correct method to the patient for the MTP. If you are in doubt, please go ahead and do an ultrasound, ascertain the period of gestation, and then go ahead and do an MTP.
Yes, very right. Then somebody says most of the patients come for irregular spotting and prolonged period after medical method of abortion, which does not respond to repeat meso even. What is the recommended management there?
You can, if it is a spotting, or if it goes beyond 2 weeks and it is really bothersome, you can give her a routine hemostat like tranexamic acid. You have to rule out infection. Sometimes the endometritis gives rise to this kind of a spotting. So if you routinely antibiotics are not prescribed in the medical method of abortions, it is only given in the surgical methods of abortions. But if in doubt, you can either, or if you have a doubt about the infection, you can give her antibiotics and simultaneously a hemostat. Tranexamic acid is good enough. 500 milligram PDS or the 1 gram PDS dose is good enough to stop the bleeding. You have to be sure about the cause.
Yeah,
It's
and
causing the
another
bleeding.
thing is that if she is going on bleeding, you also have to rule out incomplete abortion, and that is where
Yes.
that you get an ultrasound done now to see if it is incomplete. Not routinely, but if patient is having problem, and if it is incomplete in spite of repeat meso, then you can go for surgical method, as you've already mentioned. Yeah, so somebody said ultrasound shows all RPOC. Then
yeah, this is the second.
we already
same
answered
person
that.
asking the same thing. So I hope, Dr. Yamini, your query is solved now. One has.
I would like to answer previous questions, though they have been answered in the chat box. Somebody has said for twins, the indications for MTP do not change for twins. They are the same as for singleton pregnancy. Second thing was when
they are there.
Second thing was if you give ibuprofen, then the effect of mesoprostol would be, diluted. But then we are giving it mifepristone. But we are not giving fen after mifepristone. We are giving it after mesoprostol when the mifepristone has already taken the effect of priming of the cervix. And I think there was another question. Was there any other question?
Yeah, there was a related question saying that if somebody doesn't want a selective fetal reduction,
that is the twins now. See, the indication is not.
No. The question was wants to go for twin abortion. Like if for whatever indication there is a selective fetal reduction being advised, and the patient doesn't want to get one selective fetal reduction but wants to go for the entire twin abortion, then what is the indication we have to put on the form for the MTP?
There's no indication. That's what I was saying. No? Indications don't change. Whatever is the reason for MTP, if it is within the prerogative of the law, twin or singleton, the indications are same. There are no separate indications for twin pregnancy.
There is no difference between the twin and the singleton
MTP. She can get it done. Dr. Renu Manchanta had raised her hand, but she had not asked the question. Can I request her to write in the chat box what she wanted to ask? We don't want to miss anything.
Yeah, and I would even again want to request the participants to please mute themselves because it necessarily creates background noises while we are conducting the program.
We have one question, ma'am.
Renu, can you please mute yourself and put the questions in the chat box?
We have one question like previous to cesarean with MMA. We have one question, ma'am. Previous to cesareans and the role of MMA. I think it can be given in previous to cesareans because it is a first trimester medical method of abortion. So we usually have to be careful if we are doing a surgical evacuation, but MMA can be given in a patient with a previous to cesarean.
Another question about mute everybody who's not actually speaking.
Mr.
There's a
George?
lot of background noise coming.
Yes,
Yeah.
ma'am.
Please mute everybody except the speakers. Yeah.
Okay, ma'am.
One question is there. Can I take up, ma'am? Sorry, I have
Yeah,
taken.
yeah, sure.
I'm
Please
taking
go
the
ahead.
questions myself. So, what about giving pills in our clinic? What do we need? I think, ma'am, for this question, we need approval for being at an MTP center. And it can be given at a center where approval is there, and there should be basically a circular or written like where to go in case of any complications. What is the referral center after this center? It can be given. There is a form A and a form B basically provided by the government of India to get approval for your center as an MTP center. They will check your facilities and they'll give you approval in form B. You have to apply in form A, and plus, even if you are giving an MMA, you have to basically display a certificate of a referral center that where the patient has to go once she is ending up with complications, with a phone number written on that notice or a circular.
Another question is medical abortion during lactation. Anything specific?
Yes, again, you have to be sure that she is not pregnant. How do we be sure that she is not pregnant? One, you can do a urine pregnancy test. And secondly, you can basically do a physical examination. If the cervix is not soft, it is normal size. Usually the uterine size during lactation is very, very small. It is usually smaller than a normal size. So if it is like that and you are sure that the woman is not pregnant, you can definitely offer her medical method of abortion.
So if a patient is coming with a report of RPOC in her hand after having taken medical abortion by herself, will you be considering it as incomplete abortion or follow-up of MMA?
It is an incomplete abortion if it is coming to you primarily for the first time and she has taken an MTP pill on her own from a chemist or something like that. It is an incomplete abortion and you do not have to fill the forms or like the consent form and everything, 2-3 forms which I have detailed in that case. For incomplete or for missed abortions, you do not require a stringent record keeping as in the MTP cases.
Yeah, very right. Achla ma'am, for you, if a married woman comes with marital rape at 20 weeks, how do we proceed?
See, the rape is 20 to 24 weeks. She is allowed to have MTP because rape has got nothing to do with marriage. Rape is rape. When it is without her consent, it is rape. And she doesn't want this pregnancy because she's been raped, then she has that provision of 20 to 24 weeks.
Yeah, ma'am. Thanks for reiterating that. What is the safe route of administration of Mesoprostol and MMA in previous cesarean patient? And is the dose difference in previous to LSCS case?
No, it is not. It is not. It is not. You can give it by any route, but of course, the instillation by the oral buccal route, you may have a patient landing up with nausea, vomiting, little bit of fever and chills. What we have seen in our practice that the vaginal route is the best if the patient allows you and she is comfortable with the vaginal route. The dose is not a difference, even in the previous two. For medical methods of abortion, because it is up to 9 weeks, we are talking about. We are not talking about the second trimesters.
Okay, and I guess this is just a repetition of what we have again and again said. Name of the client to be mentioned in OT register or only the registration number to be mentioned?
Only the number.
Only the number.
Only
Yes, of course.
one
Only
place
the number.
that is in the admission where we are writing, when the patient is first coming to the clinic, that is one register which is kept in lock and key, and then she is coded and given a number. That number goes everywhere. Nowhere else is the name mentioned.
Yes, even in the OT register, in the anesthesia register, in the files, the number is to be there, not the name of the person.
Yeah, so the extension of that previous question, and I would like to take that. Unmarried women, a woman comes with the history of rape at 4 months. Do we send her to government setup after MLC or anything else needed? So I guess, this is a universal thing now. No center is exempted from, not making an MLC. So please, any and every person who has seen and to whom the survivor has reported has to make the MLC. And see, MLC means, or inform the police, that is the priority. Beyond that, to pursue that particular information, that is the prerogative of the patient. But you are legally bound to inform the police. You can make the MLC And if the thing is not under the purview of your setup, then only the patient is required to be referred for medical legal sampling. And of course, you cannot deny now, according to law, till 24 weeks medical termination of pregnancy if the patient desires so.
And it has
So
to be
we should
within
be very
24 hours. It is called as mandatory reporting, and this mandatory reporting has to be within 24 hours.
Yes,
If a survivor comes to you.
there is no question that whether the rape happened 3 months back or 2 months back. If she has reported to you now, it has to be informed, and that can be taken up till 24 weeks comfortably. And another thing which I wanted to say again at this point is, we do not have to mix the the MLC things with the abortion laws. Whatever is required under the medical legal examination of a rape victim, of a rape survivor, has to be done. Whatever has been mentioned under the Ministry of Health guidelines, wherever, whichever document requires the name of the patient in the medical legal documents which are permissible under the law, has to be done. It is only for the hospital records, the say if the patient is getting admitted, for hospital files and all of the things, there just the registration number or the MLC number can be mentioned. So please understand this again. Matter of confidentiality is only for, say, the public dealing, maybe with the family around, or the hospital records only. Wherever by law you need to reveal the name, you have to, because you are legally bound to do that. The next question is unwanted pregnancies after 12 weeks up to 20 weeks. I didn't understand the question, but this is written in the chat box. If MTP is to be done under anesthesia, are you writing the name of patient to be written, again the same thing, in the case sheet or OT list? In case of AUB after medical abortion, when do we start the treatment?
We usually, it is said that you have to resume, the women has to resume her cycle by 6 weeks or so. If she has a normal cycle after 6 weeks, then if she is under some treatment for AUB or any of the medical illness, she can resume with that. You have to maintain a menstrual calendar and go as per her illness. And if she does not have cycles within 6 weeks of the completion of the procedure, then you have to basically rule out the continuation of pregnancy and rule out other complications of abortion. So after 6 weeks, I think any treatment can be taken.
How many days of missed period can medical abortion pills be given?
It is up to 9 weeks, as we have said. Up to 7 weeks and up to 9 weeks as per the Government of India guidelines, it is done. Medical method of abortion can be given up to 9
Maybe
weeks.
the missing part in the question is whether to whether to confirm the pregnancy or not, or it's just the missed period and we can give the medical abortion pills.
Yes, I think
maybe that is the confusion.
Yeah, I think it can be. If the lady is sure about the cycles, it can be given, and you are sure that she is 9 weeks, not more than that.
Size of RPOC 2.5 or less.
I think we have
DNE. We have taken this up. Vaginal route is best given 3 hours before procedure.
Procedure, yes, if we are talking about surgical methods for cervical priming, best is 2 to 3 hours before the procedure. That is the day.
How do we
Monica, don't take the repeat questions because we are falling short.
Yes, actually, it is already 5 o'clock now.
I think I'll just take the last one and then we can proceed. NTD is necessary in MMA in RH negative client. I guess we know that. Can failure to contraceptive can be put as indication in cases of more than 20 weeks?
It is there. I think ma'am has just briefed her in her slides. No indications for MTP between 20 to 24 weeks.
In government hospitals, case sheets are with name only, considering high turnover of patients. If we decide to keep the case sheets under lock and key, can we make the case sheets with name?
You can make it by numbers. I think you can make it by a serial number in your registers.
I guess Dr. Achla has made it quite clear about confidentiality. Now we'll not take any more questions regarding confidentiality. So I think over to you, Achla ma'am, you can take up the next module.
Yeah, you can see my slide.
Yes, we can see.
Oh, but
no, it's end show now. I guess you would need to go to the first slide.
Okay, I'll do that again. Okay, share screen. So what I'm going to talk about now is the saver module. Very interesting very interesting concept. SAVER is an acronym for, safe abortion. Are the slides visible now? Last slide, yes. Where does it go?
It is visible.
Okay.
I think you need to go to the first slide like this only.
Okay. So this SAVER is safe abortion, values, evidence, rights for unbiased and safe abortion care. And what was the need of this? Because I already mentioned, that abortions have been legal for 50 years, but we still have unsafe abortion. We still have mortality. And on review, it was because the patient, the care seeker was not comfortable going to the care provider because of the attitude of the care provider. And why this attitude is there? Because there are certain norms in the societies. We have our own prejudice. We have our own thinking because of the way we've been brought up. An unmarried girl comes, she's scolded. A multi comes, she's not used contraception. We scold her and tell her that why she didn't use without talking to her. This module is to teach all of us to change our perspectives so that we make the abortion a memorable experience for the woman, that she has attachment with the care providers. She would listen to the care providers, whatever advice she has been given by that. And like we said, that there is an emphasis on dignity and autonomy and confidentiality. So this SAVER module, actually it is a big module with 4 days training, in which, day 1 is about new methods which have been there. Like in this, we talked about amendments. And then the second, we do certain exercises, like suppose a question is put and all the people stand in one line, and those in the answer in negative go to one side and positive answer goes to other side, and they both give their opinion why they think it should be done that way, and then they can change places after listening to each other. So this kind of an interactive thing. And then there are media stories about abortions, so they are shown, and then opinion is taken, what was wrong done by the doctor, by the patient, by the media. So it is a very, very interactive and very, very interesting module, and probably we'll be coming up with this for people who are interested, will do. So at the moment, we just have a trailer, of SAVER module. So this module aims to define respectful abortion care and highlight how norms and stigma affect services. And also we are showing you some resources of this SAVER modules. The law has changed, and we are able to give online training. There is more of medical methods of abortion being used within the PCP entity. And now we know that patients' safety always, but respect also matters, and the quality of care we give also matters. And for that, we have a role to play, especially till 20 weeks, only one provider is there. So that one provider is very, very important. And what exactly is respectful abortion care? You wouldn't find it in any books. It has not taught to us. Now the concept of respectful maternity care had come. We are all, following that. It is just a corollary to that. That like in respectful maternity care, you are maintaining the dignity of the patient. We are taking care of her safety, not we are giving her freedom from harm and mistreatment, and we are giving her informed choices. And also we are giving her support before, during, and after the procedure in abortion also. So, and simply you say that, again, I'm repeating that you treat the patient with dignity, empathy, regardless of her race, gender, ethnicity, socioeconomic status, and reproductive history, whether she's married, unmarried, she has many pregnancies, many abortions, she's had many MTPs. But once she's come to you, it is your duty to see why she had all that, and your duty to make her so comfortable that she listens to you, your advice about her reproductive and contraceptive health. And especially you can be a patient sometime, or your relative. And if you feel there's something wrong, you must speak it up. We have to listen and also speak, because communication is the key to everything. So first, I will show you a small videos. What are norms and stigmas? See, this video is from the Savor module and generally talks about the norms and stigma which are there in our society. So,
social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive.
so I think it was self-explanatory that how our behavior is affected by the norms. So because of these norms and we have this idea of stigmas, we perpetuate disrespect and abuse. There are various categories of disrespect. Some we know, like physical abuse. We don't see in abortion, but we do see sometimes in labor that juniors sometimes do resort to that. Verbal abuse is very common when we are talking to, patients. We may be shouting or screaming or, not behaving properly with them, maybe because of rash or maybe because of her circumstances. Sexual abuse, of course, is abuse of power by male over a female, or sometimes, it is the taking advantage of the woman. But stigma and discrimination, which we just showed you, this is kind of abuse, which is, don't we think of it as abuse, we think it is a norm, and this something is a stigma. The other kind of disrespect, the one in greens, when we fail to meet the professional standard of care in talking to the patient, counseling the patient, not developing a poor rapport between the patient and the provider, or when we are not having a good health system condition. These are also disrespects. And it is the right of every woman to have freedom from harm and ill treatment. Of course, we should not, when we are talking about her repo and confidentiality, one should not forget about the POXO Act, like Monica has already said, that is different from her dignity or rights, because POXO is something that has to be done. And every woman has the right to have timely and highly attainable level of care with liberty, autonomy, and freedom from force, that you will have an MTP only if you take a property, or only if you take a DMP, only if so that kind of attitude should not be there. So this is the disrespect and abuse we should avoid. So what are the domains of respectful abortion care? That the woman is free from harm and mistreatment, her privacy and confidentiality is maintained, her dignity is maintained, and her choice is maintained. Suppose she doesn't want to use a contraception at this time, you have to respect her choice, but counsel her to come at a later date. And you have to have effective communication with her. You have to provide information and also seek information, because seeking information, and you have to take an informed consent also. And continuity of support has to be there. And quality of physical environment has to be good. And you have to provide equitable abortion care. You have to have competent and motivated personnel to provide the care. And of course, provision of contraceptive advice should be there. And again, reiterating that continuity of care for her post-abortion care, as well as counseling, which should start pre-abortion and keep on going post-abortion. And when this we have already talked about, that one provider has more responsibility for counseling, for contraception, for referral and compassionate care. When we have allowing one provider to do it, the responsibility is also of that one provider to do all that. And of course, for the abortions between 20 to 24 weeks, for that special group of cases, you have to be sensitive and judgment-free and provide them timely services. And also, whenever you respect somebody, you prioritize their confidentiality, they will also respect you. And we have to remember the socio-cultural system which we have and be respectful. Then we have another video about a guide to avoiding some language which we use, you may not know, but that is stigmatizing. So this video is about that, again, from the Savor modules.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this, as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework, but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So this is now a small trailer of the saver I will show, and that would be the end of this session then. In this, totally they have described what the saver toolkit is about, and
no woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Saver, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
These are the games you can note down and you can play yourself. Cross the line, personal compass, which are there on the WHO SAVOR toolkit. They're quite interesting. And let me, before we go on to the most important session of counseling, let's see what all you have learned. You can give your answers in chat box. According to the World Health Organization, restricting access reduces the number of unsafe abortion. Please write in chat box true or false. Do we have anything in the chat box, Monica?
Yes, a lot of falses, a few trues as well.
So the answer is that if we restrict the access, it will increase the number of abortion, not decrease. So I don't know why we did not get this from everybody, because safe abortion is about being provided by a person who is qualified at a place where it should be done and by a method which is safe, and nothing else is written about the safe abortion. So we should not be restricting abortions to make it safe. The MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before she can undergo a termination of pregnancy. True or false? So what do we have, Monica?
Falses only. Oh, one true.
So,
False, true, true, false. Again, a mixed opinion.
so basically, we should know after the new amendment, a minor less than 18 years does not require the consent from parent and guardian, just a consent from the person who is accompanied here, who should be more than 18 years. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? So what do we have?
No, no, yes, no, 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 no.
So
Mostly no's.
Yeah, because we are nobody to judge. So I think I will stop sharing and Monica will take up the next session. But before that, Mr. Joe, you want to make that announcement about the how to fill up the post-test? Yes, Mr. Joel? Is he there? Our technical support is there?
Yes, madam. Yes, ma'am. I'm there.
Please make that announcement.
Yeah, madam. After this section, I'll post a link in the chat box. If you click on the link, you'll directly go to a post-test and a feedback, madam. You have to fill and you have to submit.
So this they do it before they leave?
Yes, madam. After the section, I'll post it in the group, madam.
Yeah.
After
So
the last
before
topic.
you leave, please click on the link. You can fill it later, but you'll get the information. So now we have Dr. Monica Gupta, our, bubbly secretary of AOGD, very academic, very intelligent, and very good orator who will talk about counseling pre and post abortion care and counseling. Monica, over to you.
Please enable me to screen share.
Yes, Mr. Joel, please enable Dr. Monica to screen share.
I made a post, madam. Please try once.
Yeah, okay, thank you. Yeah, so can you see the screen now?
Yes.
Okay. So after having gone through the initial modules so beautifully.
Madam, can you be a little louder, madam? Your voice is low, too low actually.
Can you hear me now?
Yes, ma'am.
Okay. So I was just saying that after having gone through the initial 3 modules and knowing about the latest amendments and of course what exactly respectful abortion care is, We now need to see another important aspect which goes hand in hand with the respectful abortion care, which is the family planning counseling. And this counseling, we all know, is can be done pre and post abortion. But I'm here to take you through this module of WHO, which says that both pre and post abortion family planning counseling are very important. And let's see how we can do that, when it's supposed to be done, what all can be done in that, and what are the various methods. So, counseling, they say, is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So, practically each and every word in this definition is kind of self explanatory and kind of encompasses the comprehensive meaning of counseling. And we have to pay attention to each and every aspect of this counseling while we are dealing our clients for for providing family planning counseling with the abortion services. So pre and post abortion counseling are an integral part of comprehensive abortion service, as important as the procedure itself. And of course, women may need help in decision making anytime during or before or after the procedure. And wherever needed, the spouse should also be counseled. This is very important in the modern era, where even the husbands have become very conscious enough, and most of the times, especially in the educated lot, they want to share the responsibility. So pre-procedure counseling has a critical role. And what you do in pre-procedure counseling is help, ensure, and help. Helping the woman to decide about termination of pregnancy, helping her to choose the method of termination, ensuring the delivery of complete information about the procedure, and of course, helping her to adopt a contraceptive method. The whole procedure of pre-procedure counseling goes this way. You are ensuring her privacy and confidentiality, which is a very, very important part of comprehensive abortion care. We've just heard. We are being non-judgmental and sensitive towards the concern of our client. We have to establish a proper rapport with her, and then using simple language, allowing the woman to clarify her doubts. And if she has now made up her mind for termination of a pregnancy, we have to assess her for the procedure in a comprehensive way. The relevance of peri-abortion family planning counseling is immense. We all know that. We can counsel her on very important 4 aspects, telling her that there would be a quick return of fertility. So she needs to be very, very careful about the future, whether to want or not want a future pregnancy. Then we have to tell her that there has to be a minimum 6 months gap before next pregnancy. It is an opportune time for contraceptive acceptance, because we all know, when she approaches you for an abortion care service, she's in a vulnerable state. And as we all know, like we have all heard about post-placental and postpartum IUCD programs, that is the time. And this similarly, like that, this is the opportune time for counseling the woman for family planning services. And we have to tell her the health benefits and better future pregnancy outcomes, provided she accepts one or the other method of family planning counsel method, according to whatever her condition is. And we must know that 90% of abortion related maternal mortality can be prevented thus. Why? By ensuring contraception to the requiring woman. Okay, so what all is included in pre-abortion family planning counseling? When to start? We can do that right at the first visit or the consultation when she has approached you. There may be a few exceptions, like when she is in immense grief state, we can kind of take a back seat for a particular moment or maybe a few days to let her be with the grief when she has borne that. Then is the right time. This clinician has to assess as on one-to-one basis. And what all has to be counseled? It has to be, as I said, that she needs to know that the return of fertility is very quick, within 10 days to 4 weeks. So she needs to know why family planning methods would be important to be adopted immediately after having gone through abortion process. Then you are helping her with all the choices available, where the method specific counseling can be done whenever she makes up her mind to choose a particular method, and wherever applicable, she needs to be told about the high risk behavior. If a woman is not willing for any contraceptive method, as doctors and as providers of respectful abortion care, we are no one to refuse MTP to her. And we try to counsel her again after the procedure. If she's still not willing, we need to call her up for follow-up in a week's time and again try counseling. So much so for the importance of family planning counseling. And while assessing the suitability for post-abortion contraception, we need to take care of a few things. We need to ensure that the abortion process is complete. There is no existing infection, no injury to genital organs, and there is chances of fresh pregnancy are ruled out. Then post-procedure counseling again has a critical role. We are ensuring the woman has understood the precautions and care needed during post-abortion period. Opportunity to counsel for contraception in case not previously accepted, this I've already told you. And this is the time when we can reinforce the need for continuing the use of contraceptive method, which was probably earlier chosen due to failure of which maybe the pregnancy happened. And then that is the time when we can open up the further basket of choices available with us. So post-procedure counseling would again include the continuum of continue, reassure, repeat. We are continuing to ensure privacy and confidentiality, reassuring her in case of any problems, and of course repeating the information about post-procedure care and danger signs again and whenever she requires that. Post-abortion family planning counseling, if she has already opted any method, we need to appreciate her effort. In the immediate care comes the arena of IUCD and medroxyprogesterone acetate. Ongoing, if she was already on oral pills, she can very well continue that. We need to tell her the follow-up protocol, and there are various methods of telling her the way by way of cards, and we need to reiterate the importance of continuity of the family planning method. If she is still undecided, you need to allay her anxiety. You need to again tell her the importance of immediate adoption of any method and the chosen method. And of course, here comes the importance of couple counseling. Maybe there are certain issues for which the woman is not very clear about, and doing a couple counseling would definitely help in such cases. And still, if nothing works, you still have to tell them that there is an availability of emergency contraceptive pills which can still save. But you need to reiterate that emergency contraceptive pills are actually not a method of a regular contraception. So post-abortion contraceptive methods, we should know, only then we can counsel. We should know that when the couple is opting for barrier methods, they can be tried started as soon as the first trimester abortion has taken place, and as soon as the sexual activity is resumed. After the second trimester abortion, as soon as the sexual activity is resumed again, they can be adopted. We need to tell them that there is no hormonal side effect, can be used without consulting a health provider, easily available, prevention of against sexually transmitted infections and HIV, and enables men to take the responsibility of contraception. So this is a very important aspect in making the spouse, making him feel more comfortable if this helps in the couple adopting this method. So what about intrauterine devices? See, after a first trimester abortion, it can be inserted immediately or up to 12 days after confirmation of a complete abortion, whenever a surgical method is adopted. But we must remember that with medical method of abortion, it is inserted around day 15 of the process, provided we have ensured that there is complete product of conception expulsion and the risk or presence of infection or anything has been ruled out. After a second trimester abortion, it can be inserted immediately or up to 12 days again after the procedure is complete and contraindications are ruled out. So additional information which has to be provided during the counseling is, it is of course a highly effective method. It provides long-term contraception. We all know 375, copper 375 provides for 5 years and 380A for 10 years, can be provided by trained doctors, any person who's MBBS level or above. Even in peripheries, ANMs and nursing practitioners can do this job easily. And PPIUCD trained doctors after second trimester abortions can do this. So there is no interference with sexual activity, and there is immediate return of fertility on the removal, and of course no hormonal side effects. All these things need to be told. As regards combined oral contraceptives, they can be started immediately or up to 7 days after the abortion has taken place. After a medical abortion, it can be started on day 3 with the dose of Mesoprostol, or within day 15 of process after confirmation of complete abortion. After second trimester abortion, it can be started anytime up to 7 days. Additional information, we all know that COCs help regulating the menstrual cycle as well, can be provided by all health workers after first screening by trained provider. No interference with sexual activity again, and of course protection against ectopic pregnancy, endometrial and ovarian carcinoma, benign diseases such as fibrocystic and fibroadenomatosis of breast, and not suitable for women who are breastfeeding babies less than 6 months. For hormonal contraception, especially the long-acting ones, which are like medroxyprogesterone acetate injectables, it can be given immediately or up to 7 days after a first trimester abortion, whenever a surgical method has been used. And after MMA, it can be started on day 3 with the dose of Mesoprostol. After a second trimester abortion, anytime up to 7 days after abortion. Additionally, what needs to be told is that again, highly effective method, confidentiality is maintained, can be provided by doctors like any other method, or ANMs or nurses after screening by the doctors for the first injection, and no interference with sex, no effect on quality or quantity of breast milk, no estrogenic side effects, and it offers protection against, like we had earlier, ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Return of fertility takes 7 to 10 months from the date of last injection. So this is here, this thing is important. It is 7 to 10 months from the date of last injection. When it comes to permanent methods, female sterilization can be performed after an abortion in the absence of any infection or severe blood loss in case of first trimester abortion, concurrently or up to 7 days. Both mini lap and laparoscopic sterilization we are talking about. And after medical abortion, it can be done only after the first menstrual cycle. So this is very important for the audience who are listening to our modules. And after a second trimester abortion, mini lap can be performed concurrently or up to 7 days after an abortion in the absence of any infection or severe blood loss. Here, laparoscopic sterilization is not recommended. We should remember that. When it comes to providing additional information, of course, this is the permanent method of contraception, not interfering with sex or breastfeeding, and no long-term side effects, and offers protection against ovarian cancer. As regards vasectomy, again, the spouse or the male partner has an important role because this is entirely dependent on him, and it's independent of timing and procedure of abortion. Very effective permanent method, again, no interference with sex, but yes, the couple must be counseled to use another contraceptive method for at least 3 months or till there is azoospermia. So this is regarding a pictorial representation of how soon a method of contraception can be used after vacuum aspiration, which was beautifully described by Dr. Anuradha. Combined oral contraceptives, centromin and tubal ligation can be done anytime after vacuum aspiration, and injectables can be given within 7 days, and IUCD can be inserted up to 12 days after the procedure. So now comes another important aspect which I wanted you to apprise you all is the sexual reproductive services. And in this era of we have become very well versed with the in this era of COVID about teleconsultation and other technologies. So how are these technologies helping us in leveraging and in providing our services? So there are things like teleconsultation, telecounseling, teleguidance, telereference, or telelinkage. When it comes down to providing information, education, and counseling, it can also be done the techno way or the technology way. We all know there are various websites which provide information. A very important one being Hamdo. Then there's social media. Most of you must have heard about Ask Tanu anything to feel like. So this is an important platform which has been providing such services. Then YouTube, of course, you just with a click of button, you just ask anything and some or other platform would be providing you information on this platform. Infographics, helpline, the governmental and all big organizations around the world have provided education and patient education pamphlets, programs, PDFs, all ready to seek technology information is available on various platforms like WHO, Ministry of Health website, RCOG, which we are commonly following. So when we talk about technology, everything comes with a bit of drawbacks as well. So when we do the SWOT analysis, which means the strength, weakness, opportunity, and threat analysis of teleconsultation, of course, strengths are COVID era. This has been a boon to us. It has become approachable throughout the process. The confidence can be built easily, but and it just helps spreading the awareness in a much easier way. But definitely the weakness being there is no face-to-face consultation, and that feel of talking to patient personally, that verbal, non-verbal gestures may not be that evident through the techno way. And of course, demonstration in a comprehensive way may not be very, very much possible through teleconsultations. Opportunities, of course, privacy and comfort is definitely one of the opportunity. It is cost saving. It cuts down the number of visits. So many remote area dwellers are quite comfortable in just click of button. They are consulting with the provider. So we should not lose on such opportunities. And threat being, yes, there may be a missed opportunity for maybe the information provided is not complete, which probably when you see the patient or consult or examine as a whole, you might be able to elicit in a much better way, and there may be misdiagnosis of certain things. Applicability of components of comprehensive abortion care, assessment, counseling, and follow-up. All three important aspects we have discussed, but we'll just in nutshell, I'll tell you. Assessment of what? Assessment of confirming diagnosis and contraceptive needs. Counseling through techno-way can be done through video conferences in Zoom. Follow-up in techno-way can be done through hybrid services. Patient may or may not visit you, but then if teleconsultations are there, you can approach them and at least have a contact with them. It may be one visit or maybe 3 visits after a medical abortion. And key messages, just to sum up, you have to realize the need of post-abortion family planning counseling, because that makes it a comprehensive abortion care service, because respectful abortion care goes hand in hand with family planning counseling as well. And bringing the couple on board and striving for 100% coverage, capitalizing on the basket and availability of post-abortion period, and of course, use of technology as far as possible with the scope of, there is always a scope for entry in comprehensive abortion care services as well, like any other entity in medicine these days. We have seen it all. But the concern being policy making, malpractices, cost services, and access to such kind of services by all. And adolescent reproductive health needs both online and offline services provision. So thank you again for patient hearing. And as Dr. Achla had initially reiterated, I'll once again tell you that before you leave the meeting, there'll be a link which will pop up, and it will be in chat box as well, as Shriman had initially told. And you have to complete that questionnaire completely to as a post test to receive the certificate from FOXY WHO. Thank you once again.
I think you can all see this. You can just click on the link and you will be getting the form. Has everybody got that link? After taking that link, you can all leave, and I hope we have been able to do justice to the program, and you have probably gained something from it. So can we have everybody video?
Ma'am, where is the
so that
link?
there can be a photograph. It is there in the chat box.
Okay, it's in the chat box. Okay.
Yeah, it's there, and everybody can put their videos on, and screenshot can be taken of the people who attended. Yes, I can see Yashika. Yeah. Abhilasha, you are rotating. Straighten yourself, Abhilasha Garg. Yes. Yeah, so we can have somebody is taking the screenshot. Monica, you can take it if it's not being taken by. Can you take it, Monica?
Yeah, I'll do that one.
Take all the 4 pages, because this is 1 page and we have 4 pages.
Oh gosh.
Thank you, Dr. Achla and Monica. It was a fabulous session. It was really very enjoyable and very informative. Thank you.
Good. So we have the screenshots, Monica. Thank you, Meenakshi.
Doctor.
I think I must thank Dr. Vandana Gupta, who has made so much effort for this, Never before in the previous programs, I saw so much effort, how much Vandana Gupta has put. I think.
Thank you, ma'am.
Yes, kudos to Vandana. She really put in a lots and lots of effort.
And of course, with the effort, that enthusiasm from the participants makes it all.
Yeah,
So
Deepa was also helping, but I think Vandana was too good.
We were really overwhelmed to see the, our mailbox buzzing with mails. I want to register. I want to register. So it was a very, very overwhelming feeling in this training.
So anybody who is interested will be soon, the Savor module, 4 days training, that is very dedicated training to change your own bias attitudes by WHO. We can, those who interested can send on the AOGD mail, and then if there's a group made, then we can do a program, or the Savor module.
Dr. Neeti, you have asked till what time we can fill and submit the post-test form. You have to do it now before leaving the.
No, it's not that. I think you
see,
just download the form and then you can mail it, But better
just have to click on the link, madam. Then you can redirect to the post-test page. Actually, there is no need to download also. You have to just click on the page and you will be redirected to the post-test and feedback page.
As per our last experience in the previous training, it's always advisable if you do that post-test, because these are the same questions which you must have done in the pre-test, and it's a quick recap of what you gained from this training. So if you fill these forms now, it will really help the back-end team and the FOXY people to be providing you with the certificate soon.
Ma'am, I'm so sorry, I just missed the pre-test. So will I be applicable for the certificate?
But how have you joined if you missed the pre-test? The registration form is the pre-test.
No, I did got myself register, ma'am.
Yes, that is the pre-test. That is the pre-test.
Okay. I thought there was a question here.
No. That the form you fill is kind of questions you answer. That is what it is. The
okay, ma'am. That I did, ma'am. That I did.
Yeah. Because you can't be here without that. You won't get a link. So we can all leave now if you have all got the. If you've all got the, link. Thank you, Dr. Rajkumari, for joining.
Ma'am, it was wonderful. It was a revision, but still very nice.
That's what we need.
All the AOGD team and especially our Vandana from East Delhi Gynae Forum. She has really worked hard.
No, it's all Delhi together, There's nothing like that.
But you are doing a very good job.
Yeah. So I think we can all leave. I think, Monica, we have the photographs.
It was very good, Achla. Very nice.
Thank you. Thank you.
Very
Anita. So, okay, good day to everyone and happy Holi to everyone.
Happy Holi.
To everyone who have joined today.
No, those who have not joined, please pass on the message.
Thank you, Dr. Achla, for your lovely comments.
Yes.
Happy Holi.
Thank you. Happy Holi to everyone.
Hey, Meenakshi. Bye. Bye, everyone.
Bye. 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 Bye, Dr. Raj.
Bye, Vandana.
Bye. Bye.
Sad day for today. It's a